So hand me the knee model. The thing that really surprised me, so during my surgery, my knee replacement surgery, I had a friend who was in the operating room. She was the rep for the company, the Conformis company. I had her take pictures throughout the surgery, and it's a little shocking to see.
Don't look at them.
I know, I won't post those because it's a little much. But your knee is exposed, so you can see in the pictures the ends of both the bones for good reason, because the surgeon's got to get in there and make the cuts on the bones in order to put the implant in. So there's got to be enough working room in there to, like, if you hold up that implant, it's big.
Yeah.
I mean, you've got to slip this
You got to get
somehow onto the femur.
Yeah, you got to get it on there. So what I would tell people if they asked about their incision length, I said it'd be like, here's the top of the patella. You can see the patella there. The incision would be about two of my finger breadths above, down to the bony bump on the front of your knee called the tibial tubercle, where this tendon attaches. So I have to get to there, and I have to get to there so that I can move the patella over. Some people, including myself, experimented a little bit on trying to not cut up into the quadriceps tendon when you go in. Now this looks like the tendon just ends, but really on the side of your quad tendon, muscle comes into here and into here. And the standard operation then is to cut along in this quad tendon, leaving a little piece of quad tendon on the muscle, and then so you can sew it back together.
Okay.
Some people tried doing a little more minimally invasive, and where the quad muscle comes down, staying below that, instead of going up in here and potentially violating a little bit of the quadriceps tendon and muscle, you stayed under the muscle and flipped everything over. And I did several of those. I honestly did not see a difference in the patient's pain or ability to rehab afterwards.
Okay.
So I quit doing that. It took more time, so then they're in the operating room longer, and so I didn't do that. Some people actually come in from the side. You make it an incision on the side of the knee, on the outer side. I've never seen that done, but I know somebody at the University of Washington was doing that for a while. I don't know if they still are. I would find that to be very hard, and you're not looking at the knee in the traditional way.
Right.
So.
And you still have to get the bones covered, cut and covered.
Yeah. So.
Interesting.
I think the minimally invasive thing has kind of gone away as a marketing tool, and people just do the incisions that they need to do to get the operation done.
And that makes sense. I mean, it is an invasive surgery,
Yeah.
no matter how you approach it, because the ends of your bones are being cut off and essentially capped with the implants.
Yeah.
And you, frankly, I want my surgeon to have the room to do that.
Yeah.
And the scars, I think they're just kind of a cool part of your own story of who you are. There's lots that you can do for scar management with making your scars a little more supple after the surgery. I'll cover that in a different video. Sometime we'll talk about scars and scar massage and what you can do for that.
So once I've gone through the skin, then I would go along the side through the quad tendon and along like this, so that we could push that over and bend the knee to get at your femur and tibia. And then while your knee was straight, I would turn this over like so.
And lift that up a little bit.
Yeah, and measure this thickness. We would measure the thickness of your patella. I would take a cut off the thickness of the plastic that's going to go on there, so that I recreate your anatomy. So I don't want to make your patella too thin. You don't want it to be less than 10 millimeters thick after it's cut, because then it could break. The patella would be stressed and possibly break. And so if your patella was 34 millimeters thick, I want the finished product to be 34 millimeters.
Right.
Give or take a millimeter, this is fine. So we would do the patella, then we'd slide it over out of the way, bend the knee. In a standard knee replacement, we would drill a hole here and put an alignment rod up inside your femoral canal, because it's hollow, and we'd go up there like that. And then off of that rod, I could put a jig on here that would let me make the cut off the end of the femur like this in the correct alignment. Cut it off like that. Then we could measure the cut surface, so I have a front to back measurement. That then like a miter box basically goes on the end of the femur, so that I can make the front cut, the back cut, and then 2 chamfer cuts, so that it's the shape of the
Right.
back side of this implant. You can see, yeah, the implant is that's upside down. Just turn it
here,
like
turn
that.
it around the other
Yeah,
way.
but
Yeah.
you can see the back of that implant there has those surfaces. And then once the femur's done, we would line up a jig on your tibia here so that I could make a cut off the top like I showed on that model to have this be flat with the floor. Look down on that cut surface, put my templates on there, like is it a size 2, 3, 4, 5, 6, whatever, and then pin something in place so I could drill out the hole for that stem to go in.
Right,
Yeah.
okay.
And then we put all the trials on, all the trials, put it back like this, and kind of run it through motion, make sure it's stable, everything fits nicely, I'm happy. And then you take all the trials off, prepare the bone by power washing it, basically.
Wow.
You spray irrigate to get all the little fat globules out of your marrow.
Oh, no kidding.
So it's a really nice, dry beehive, honeycomb. The bone is like a lattice work or a honeycomb. And you want to get that nice and dry before you either put a cementless implant on or lather it with bone cement and put the implants on, wipe away the extra cement. The cement hardens in about 10-15 minutes. And
That's good.
that's why we can, while it's being sewn up, it's hardening. And if you were awake, you could walk.
Right. Well, it wasn't long after I came out of the recovery room that a PT was in and moving my leg, and I was up walking, which is pretty
Yeah.
amazing.
Once your block wears off,
Yeah.
most of the time people have a spinal block and sedation.
Okay.
They can be semi-awake, napping, light nap, or be out. So
I chose out.
yeah, you didn't want to hear the power tools. Huh? Yeah. Yeah.
It's a little bit of carpentry going on.
Human carpentry. So most people want to be asleep, and yet it's better to have a spinal block in sedation, so you're out, than being fully put to sleep. Although that's kind of the choice of the anesthesiologist, depending on your airway. And
Okay,
they,
yeah.
They need to make it safe for you.
Right. Yeah, absolutely.
There's less blood loss, less chance of clotting and so forth with a spinal block. And the other nice thing is you wake up in the recovery room, no pain.
Yeah,
Because
that's
asleep,
right.
You're asleep from the waist down, and it's not like you wake up from a general anesthetic and you're going, what great white shark just bit
Oh,
me?
yeah.
So-
Okay. No,
Yeah.
I'm pretty sure I had that.
I'd advise a spinal block if you can.
Yeah.
Other options would be going to sleep and having a nerve block.
Hmm.
You can have a femoral nerve block, which is up in your groin, or an adductor canal block, which is down by the knee, which spares your quadriceps. So you don't put your quads to sleep with that one.
Okay.
But if it doesn't work, not every block works. If it doesn't work, you're going to wake up in discomfort.
Yeah.
So I was a big fan of the spinal blocks, some sedation, whatever they want, and then we would, instead of having a catheter or a nerve block, I wanted to keep their quads active, but I would use this drug called Exparol. It was like a 72-hour Novocaine, and I used it on you. I
Yeah.
injected it all around everything I've touched or cut. I injected it to numb it, and then I close, and then it gives you potentially 72 hours of pain relief. It does help. It doesn't take all the pain away.
yeah, no, it totally helps. And the first day is not so bad. It's after, it's the days after that
When you
that
start doing too much, you mean?
Now who said that? Okay, so with implants, we talked about how a doctor chooses their manufacturer. It's
Well, we could talk about that, and we didn't really cover the conformist.
Oh, yes.
The difference
Why?
between it and a custom, and a difference between that and an off the shelf.
Yeah.
But so the reason I used the custom on you and a few other people is if the femur is deformed, say this bone up here. Why don't you take that and I'll get the other
model, yeah.
The model. So the first time I used the conformist system was because a patient had been in a terrible motorcycle accident back in the 60s and 70s, and his femur was treated in traction and it healed crooked. So as I mentioned, when we do knee replacements and I want to drill a hole in the end of the femur and slide the rod up the whole length of the femur, If it's crooked and scarred shut, the canal, you can't do that. So what I did was I used this company Conformis, where I got a CAT scan on the patient ahead of time, and the CAT scan then is used with their proprietary software to determine where, it builds the model of the patient's knee, and then using that, they design jigs and implants. So the jig snaps on the end of the femur. So like I would open up the knee like this and put a kind of a plastic cap on it, and it would lock on perfectly like a glove because all the spurs were built into it.
Right.
And it would snap on, and it had slots. So I would just put my saw blade in and saw in the cuts that were already there. Same thing on the top of the tibia. It would lock on right here like this, and I'd pin it in place, and it would determine where my cuts were. So it was kind of like robotics preoperatively.
Right.
Before getting into the OR, I had jigs that told me exactly where to cut, instead of me normally looking at it and kind of going, well, a jig, look, yeah, right there, and I'm going to pin it right there, But if well, back to the Conformis, it custom made the jigs and the implants. A lot of companies have custom jigs, but the implants, then you're just putting on the standard.
Okay.
Whereas if you look at the implants on your model, that reconstitutes the shape of your knee the way it was before it became
Exactly,
arthritic.
yes.
So it's exactly you. We don't have enough good peer-reviewed literature to say that's actually going to be better, symptom-wise, last longer and everything. But given time, I think the Conformis has been used about 11 or 12 years now. The surgeons that do a lot of them and maybe help develop it, they do believe that the results are better. But there's some bias there, I'm sure.
Well, yeah, it makes sense to me because it's made only for my knee shape, only for my body. It wouldn't fit anybody else.
Right.
It's made just for me. So I loved the idea of a designer knee.
Designer knee,
and that it was going to work with my conditions from that osteotomy. I had a bend in my femur. And so a traditional off-the-shelf knee surgery was going to be very challenging.
Yeah.
And when Dr. Thorpe said, hey, I've got a solution, finally, let's do this, then I thought, okay, I'm getting closer to the replacement.
And then long-term results of knee replacement, if you look at the knee registries where everybody puts their knee replacement into a registry, and that's all surgeons, ones who do 500 a year and those who do 20 a year, and all implants and so forth in a country, say the Australian or the English or now we have an American registry. It all comes out about 80% of people are very satisfied with their knee replacement. That leaves 20% that aren't fully satisfied, right? So that's why companies have developed things like the Conformis, and now why robotics have been developed to help make all the cuts even better.
So talk a little bit about the robotics, because I get questions about what do you think about robotic surgery? And since I didn't have one, I don't have direct experience with that. Well, I did. I had like the pre-robotic surgery.
Yeah, we didn't use a robot, but we used computer software ahead of time.
To create the jigs.
To create the jigs and create the
That's
implants.
where the cuts were, and the implants.
But again, none of the studies have shown that a good surgeon doing lots of knee replacements and so forth, that his results are worse than the robotic knees. It's going to take... so,
or better. I mean, either way.
Better, there hasn't been a difference shown yet. Maybe it will. But I think what's true and most people talk about is the outlier knees, the ones that, were cut too deep or cut too shallow or a little bit crooked this way or a little bit crooked that. It's going to narrow that, so that more and more of the knees are in the valley. Like I said, it could be tilted 3 degrees on the tibial component, that a higher percentage are going to be in there instead of, this one's at 7 degrees off, because those are the ones that you don't want. So robotics came about. It's very expensive. And that's why, like, my surgery center couldn't afford that.
Oh, okay. And so what happens with during a robotic assist surgery?
Yeah, so there's there's two main types of robotics you can think of. One is where intraoperatively the surgeon takes a little laser pin and touches the femur in several places, touches the tibia. It's called digitizing. So the computer knows where your anatomy is, knows where your bones are. And then off of that, the computer tells you where your cut should be made. And so the computer sees your saw, and you're looking at a screen, and your hand is, you're in the right plane, up or down, side, whatever, and you make the cuts.
Okay.
And so the computer helps guide you to make those cuts, but you're doing it yourself, based on what you see on the screen. Another way is you've got a robot itself, and the saw is in the robot's arm.
Okay.
It's an arm off of a machine, and the arm is going to only go where it's supposed to go to make that cut, but you have to push it.
Okay.
And you have to stop. You can't just. It's not going to stop when you get to the end of the bone. I mean, you have to guide it,
right.
But it's not going to let you tip one way or the other, or this way or this way. So it's it's just those are the two main ways that the robot is used to help, like I say, narrow lessen the chance of imperfection.
Right.
Yeah.
Okay. Well, that makes sense.
Yeah.
I mean, I was glad that I had the surgery the way I had it. So if someone was to ask you, should I have a robotic or should I not have a robotic, what would you say to that?
Right now, I would say that make sure you have the right surgeon.
Yes.
So, and many of the good surgeons out there that are doing a lot of knee replacements do have robots because they're at a center that can afford it.
Yeah.
But if you have a really good surgeon who's done tons of them and doesn't have a robot, you should be fine too.
Okay.
Yeah, you don't go and see somebody who's doing 10 a year. That's what you. Yeah.
Yeah, right. I want somebody who does thousands a year because they've seen so many different kinds of knee conditions and they've been able to.
Yeah.
have lots of practice.
100 a year is a pretty good number. If you're doing 100 knee replacements a year, you're considered a total joint specialist. Yeah,
okay.
Yeah. So.
All right, that's a good guideline.
Yeah.
Okay, I think we're about to the end. What is some of the most important advice you can offer about choosing a surgeon and how much choice you have in the type of knee replacement that you have?
Well, every total joint surgeon is going to have the equipment or the brand that they like. Now, my full knee replacements were either Conformis or the Johnson & Johnson DePuy. When I did my partial knees, and that's where you maybe were arthritic only on one half of the knee. So this is a right knee. If this side was fine, kneecap joint was fine, but you were just bone on bone here, then I'd make a little incision and do what's called a uni. And a uni is kind of a cute little thing here.
That's cute.
Yeah, it's you just replace one side. It's gonna be hard to show, but if you hold that up. So this is the metal, and it would just be covering. There we go. So it would just be covering the end like that, so that when they're straight, it covers the back and the end and a little bit of the front, but it doesn't get up into the kneecap joint. And then the tibial tray, this would just be sitting in
it's
here.
just a little halfer.
Yeah, just a little half like this. So you just replace here and here, and that's it. So 2/3 of your knee isn't even touched. And a uni, if you qualify, is a nice, simple outpatient operation. You go home the same day, which knee replacements are sometimes also.
Yes.
And it feels more like a normal knee to you.
Oh,
because
interesting.
you don't take any ligaments out. In full knee replacements, you take out the anterior cruciate ligament, and some people take out the anterior and posterior cruciate ligaments.
Yeah.
I tended to leave the PCL
and those are those two ligaments, right, in the center there.
Here,
yeah.
here. Yep. So the less we change your anatomy, the more normal it should feel.
Right.
Yeah. So, unis were really nice to do. The cute little, implants and incisions.
They're so
and-
cute.
Yeah.
They're little.
Everybody should have one. Right?
I had full knees.
Yeah.
And the one thing that I notice with my full knees is that when I walk, my knees, I swear everyone else could hear it, but there's a knocking sound that I can hear, and it's just that.
It's hard metal on hard plastic.
It's this.
Yeah.
Probably a little bit of laxity in my collateral ligaments, and I think I've got the posterior. I still have my posterior.
Yep.
Yeah.
Yep. And we normally have that play in our knee, but because it's cartilage, you don't hear it.
Right.
You know, I always would do this. I go, you can't hear that, but
You can hear
my
that.
knuckles.
Yeah. Okay.
Yeah.
That makes sense.
Yeah.
Well, that wraps up our discussion on implant pieces and parts.
One other thing I was
With
gonna
one
say,
more thing?
One other thing, the line I would say is, don't come into your doctor's office and say, I want implant type A, because if he's not using that implant system, it'd be like asking a jockey to ride a different horse, or a race car driver don't use that car you're used to, use a different car. You know, they don't want to do that. They want to use the system that they've got experience with, and they know the jigs, because you can read the instruction book and it says to do this, but when you really start using it and honing your expertise with a certain systems, there's little tricks, little things that you get better and better and better at. So, you know, you want the surgeon to use the implant system, you know, one of the popular ones that he's used to, or he or she are used to.
Yes.
Yeah.
Okay, that's a good point.
Yeah. So.
Because you don't really want your surgeon to be reading the instruction manual while they're replacing
Although we
your
all
knee.
had to at one point.
Yes.
Yeah.
All right. Well, thank you so much
You're welcome.
for our time together. I always enjoy it.
Yeah.
And I hope you enjoyed it as well. If you did, please subscribe to this channel, Healthy Knees for You. I post a new video every week. I think we'll have one more interview with Dr. Thorpe, probably lots more in the future. But stay tuned for that, and I look forward to seeing you next week. Bye for now.